Right now, somewhere in the world, someone is likely undergoing a surgical procedure performed outside any legal, regulated medical system by someone operating entirely outside official licensing and oversight. This shadow medical economy exists across numerous countries, driven by a combination of desperate patient need and, in various documented cases, considerable criminal profit. So, what does this world actually look like? Why does it persist despite the very real dangers involved? And what do documented cases actually reveal about who ends up practicing and receiving medicine entirely outside any legal, regulated system? Let's dig into this properly, treating this topic the way responsible investigative journalism and public health research generally approach it, focused specifically on understanding the underlying circumstances and documented patterns, rather than sensationalizing truly disturbing specific details for their own sake. Let's start with the basic question of who actually ends up practicing medicine outside legal, regulated systems, because understanding this varies considerably worth exploring directly. Documented cases generally fall into several distinct categories. Some individuals performing unlicensed medical procedures received genuine medical training in their home country, but face significant legal or financial barriers preventing them from obtaining recognized licensure in the specific country where they're currently living and working, sometimes connected to immigration status complications or the considerable expense and bureaucratic complexity involved in having foreign medical credentials formally recognized within a new country's specific regulatory system. Others involved in unlicensed medical practice have little to no genuine medical training at all, representing a considerably more dangerous category worth distinguishing clearly from the first, since these individuals typically lack even the underlying medical knowledge and skill that might otherwise partially mitigate the inherent risk of operating outside proper regulatory oversight and legal medical infrastructure. This distinction matters considerably for understanding the actual documented risk spectrum involved in this broader topic, since a seriously trained medical professional operating outside formal licensing, while still practicing illegally and without proper oversight, generally poses a meaningfully different level of direct medical risk compared to someone with minimal or no legitimate medical training attempting similarly serious medical procedures without either proper training or proper oversight. Let's talk about why patients actually seek out unlicensed medical care in the first place, because understanding this underlying demand helps explain why this shadow medical economy persists despite the very real, well-documented dangers involved. Cost represents one of the most significant, consistently documented factors, particularly in countries with expensive, difficult-to-access formal healthcare systems, where legal medical procedures can carry a price tag entirely out of reach for many patients, particularly for elective or specialized procedures not covered by available insurance or public healthcare systems. Legal status also plays a significant, well-documented role, since individuals without legal immigration status in a given country frequently face severe practical barriers to accessing formal healthcare systems, sometimes driving them toward unlicensed alternatives despite the additional risk involved, out of genuine practical necessity rather than any kind of careless disregard for their own safety. Certain specific categories of medical procedure also show up disproportionately within documented black market medical activity, including certain cosmetic procedures, particularly among patients unable to afford legitimate cosmetic surgery, but still strongly motivated to pursue these specific procedures. And in certain documented regions and contexts, various reproductive health procedures where legal access remains severely restricted or effectively unavailable within that specific patient's actual geographic and legal circumstances. Let's talk about a few specific, well-documented historical cases that investigative journalists and public health researchers have examined in detail, because grounding this discussion in concrete, real examples helps illustrate the broader patterns already discussed throughout this topic more clearly. Investigative journalism in various countries has documented cases of individuals with genuine but foreign medical credentials performing procedures ranging from routine dental work through more serious surgical procedures, operating out of private residences or informal clinic settings specifically to avoid the cost and bureaucratic complexity of formal licensing processes. Other documented cases involve individuals with backgrounds in adjacent but distinctly different fields, including veterinary medicine or emergency medical technician training, applying that partial, related medical knowledge toward human medical procedures well beyond what their actual training and legal scope of practice would properly permit. These documented cases illustrate the considerable range of backgrounds and circumstances involved across this broader phenomenon, extending well beyond any single, simple narrative of who actually ends up practicing medicine outside legal, regulated systems. Let's talk about how unlicensed medical practice differs across specific procedure categories too, because this represents an important, more granular dimension worth exploring specifically. Public health researchers studying this broader topic have found meaningful differences in risk profile and and typical circumstances across different specific categories of unlicensed medical activity. Certain relatively minor procedures, when performed by someone with at least genuine foundational medical training, even without proper local licensing, generally carry more moderate documented risk compared to more serious surgical interventions attempted without adequate training, equipment, or emergency backup capability specifically available should serious complications develop during or after the procedure itself. This distinction matters for how public health researchers and policymakers actually approach and prioritize this broader issue, since the most severe, most urgently concerning documented cases generally involve serious surgical procedures attempted under circumstances offering minimal safety margin should anything go wrong during the actual procedure. Let's talk about the specific role financial desperation plays on the provider side of this equation too, because this represents an important, often underexplored dimension worth addressing directly. Beyond patients seeking affordable care already discussed extensively throughout this topic, some individuals providing unlicensed medical services are themselves driven by real financial desperation, including cases of legitimately trained foreign medical professionals unable to secure recognized employment within their new country's formal healthcare system, sometimes due to credential recognition barriers so severe and expensive to overcome that unlicensed practice becomes, in their own difficult circumstances, one of relatively few available ways to actually apply their genuine medical training and generate necessary income. This detail adds important additional nuance worth appreciating, since it demonstrates that the individuals involved in this broader shadow medical economy, both as patients and as providers, frequently face seriously difficult circumstances driving their specific choices and decisions, rather than the phenomenon being purely explainable through simple criminal opportunism alone. Let's talk about how investigative journalists actually research and report on this difficult topic responsibly too, because this represents an important methodological consideration worth addressing directly. Responsible investigative journalism covering this topic generally emphasizes careful verification of documented cases, direct engagement with affected patients, and, where safely possible, with practitioners themselves, and careful attention to presenting the underlying structural and economic context driving this phenomenon, rather than presenting isolated, sensationalized individual cases disconnected from this broader explanatory context. This careful journalistic approach mirrors the same responsible scholarly methodology already discussed in other explorations of difficult historical and social topics throughout this broader series, emphasizing structural understanding over sensationalized specific detail. Let's talk about the specific role of medication and supply access within this broader shadow medical economy too, because this represents another important dimension worth exploring specifically. Beyond surgical and other hands-on medical procedures already discussed extensively throughout this topic, documented cases also involve unlicensed distribution of prescription medications and medical supplies, sometimes connected to legitimate medications diverted from proper regulated supply chains, and in other documented cases involving counterfeit or improperly stored medications carrying their own additional serious health risks entirely separate from whatever underlying medical condition a patient originally sought treatment for in the first place. This detail broadens the overall picture already established throughout this discussion, illustrating that unlicensed medical activity extends beyond direct hands-on procedures into a considerably wider shadow economy involving medical supplies and medications more generally, all connected by the same underlying combination of genuine patient need and inadequate legitimate access already explored extensively throughout the rest of this topic. By the way, if you want to go even deeper into the secret lives of ancient humans, I just launched a full course called The Secret Lives of Ancient Humans. 10 modules, 3+ hours of content covering everything we never talk about on YouTube. What they feared, how they communicated, what hunted them, and much more. Plus an exclusive PDF guide included. Link in the description. See you inside. Let's talk about international variation and how different countries specifically address this broader issue too, because this represents an important comparative dimension worth exploring before this discussion concludes. Countries with more comprehensive, more truly accessible universal healthcare systems generally show measurably lower documented rates of unlicensed medical practice compared to countries with more restricted, more expensive healthcare access, providing indirect but meaningful additional supporting evidence for the broader structural explanation already discussed extensively throughout throughout this topic. This comparative pattern, observed consistently across multiple different public health research studies examining this specific question, reinforces the conclusion that real healthcare access and affordability represent the single most significant underlying factor determining how prevalent this kind of dangerous, unregulated medical activity actually becomes within any given specific country or region. Let's talk about the specific, well-documented dangers involved in unlicensed medical practice too, because this represents an essential, direct public health concern worth exploring specifically. Unlicensed medical procedures carried out without proper sterile technique, appropriate medical equipment, or reliable access to emergency intervention if serious complications develop carry dramatically elevated risk of infection, severe complications, and death compared to the same procedures performed within a properly licensed, regulated medical setting with appropriate safety protocols and emergency backup capability in place. Documented cases studied by public health researchers and investigative journalists consistently reveal significantly elevated complication and mortality rates connected to unlicensed medical procedures compared to legally regulated medical care, reflecting the real, serious danger inherent in bypassing established medical safety standards and oversight. Let's talk about the specific organized criminal networks sometimes involved in this broader shadow medical economy too, because certain documented cases involve considerably more organized, deliberately criminal enterprise beyond simply an individual unlicensed practitioner treating patients independently. Investigative reporting and law enforcement records have documented organized networks specifically involved in certain categories of illegal medical activity, including, in particularly severe documented cases, illegal organ trafficking operations exploiting vulnerable individuals, sometimes involving deceptive recruitment, or, in the most severe documented cases, direct coercion of vulnerable people into providing organs under circumstances involving little genuine informed consent or fair compensation. These particular cases represent some of the most serious, ethically egregious documented examples within this broader topic, involving direct, serious human rights violations extending well beyond simply providing medical care outside proper legal licensing and oversight. Let's talk about how law enforcement and public health authorities actually investigate and prosecute this kind of illegal medical activity too, because this represents an important, directly relevant dimension worth exploring specifically. Investigating unlicensed medical practice presents genuine, significant, practical challenges, since this activity deliberately operates outside official record keeping and typically relies on discretion and limited advertising specifically designed to avoid detection by law enforcement and regulatory authorities. Law enforcement agencies and public health authorities generally rely on a combination of patient complaints, particularly following serious medical complications requiring emergency legitimate medical intervention, along with undercover investigation techniques and coordination with immigration and public health agencies to identify and eventually prosecute individuals engaged in this kind of illegal medical practice. Let's talk about the specific legal consequences individuals face when convicted of practicing medicine without proper licensing too, because this represents an important, directly relevant legal dimension worth exploring specifically. Legal consequences vary considerably depending on the specific country and jurisdiction involved, along with the specific severity of harm caused to any affected patients, but generally include significant criminal penalties, including substantial fines and imprisonment, particularly in cases involving serious patient harm or death connected to the illegal medical procedure in question. Legal systems generally treat cases involving serious patient harm or death considerably more severely compared to cases where patients received unlicensed care without suffering serious documented medical complications, reflecting the underlying legal principle that the severity of legal consequence should generally correspond to the actual severity of harm caused. Let's talk about how this issue connects to broader questions regarding healthcare access and inequality too, because this represents an important, socially significant dimension worth exploring before continuing this discussion further. Public health researchers and healthcare policy experts studying this broader topic generally emphasize that unlicensed medical practice tends to flourish specifically in contexts where legitimate, affordable healthcare access remains really difficult or effectively unavailable for a significant portion of the population, suggesting that addressing this issue effectively requires addressing these underlying structural healthcare access problems directly, rather than relying purely on criminal law enforcement alone to address what represents, at its underlying root, a significant healthcare access and affordability problem affecting real, vulnerable people facing truly difficult practical circumstances. This detail is worth including because it reframes this topic in an important way worth appreciating directly. While the specific individuals actually performing illegal, unlicensed medical procedures clearly bear direct legal and ethical responsibility for their actions, particularly in cases involving serious patient harm, the broader persistence of this shadow medical economy reflects deeper, structural problems regarding healthcare access and affordability that extend well beyond any single individual practitioner's specific personal choices and actions. Let's talk about documented efforts to address this underlying problem through legitimate policy reform too, because this represents an important, constructive dimension worth including before wrapping up this discussion. Various countries and healthcare systems have implemented specific policy reforms directly aimed at addressing the underlying factors driving demand for unlicensed medical care, including expanded access to affordable healthcare services regardless of immigration status, streamlined pathways for foreign-trained medical professionals to obtain recognized local licensure, and expanded public health outreach specifically targeting communities at heightened risk of turning toward unlicensed medical care due to genuine access barriers. These kinds of structural policy interventions addressing underlying access and affordability barriers directly generally prove considerably more effective at reducing unlicensed medical practice over time compared to relying purely on criminal enforcement alone, which tends to address individual cases after serious harm has already occurred, rather than preventing that harm from occurring in the first place. Let's talk about harm reduction approaches specifically developed to address this issue too, because this represents an important, practically constructive dimension worth exploring before continuing this broader discussion. Some public health systems have developed specific harm reduction programs directly targeting people who have already received or are actively considering unlicensed medical care, providing accessible follow-up medical attention without requiring disclosure of the original unlicensed provider, or triggering immigration or legal consequences for the patient themselves, specifically designed to reduce the serious medical harm already discussed extensively throughout this topic, even in cases where the underlying unlicensed procedure has already taken place. This harm reduction approach reflects a broader public health principle worth appreciating directly, prioritizing immediate patient safety and positive health outcomes over punitive approaches that might otherwise discourage patients experiencing complications from seeking necessary, legitimate follow-up medical care out of justified fear regarding legal or immigration consequences. Let's talk about how community health organizations specifically work to address this issue at the community level too, because this represents another important, constructive dimension worth including before this discussion concludes. Various community health organizations, particularly those serving immigrant and other populations facing significant documented healthcare access barriers already discussed extensively throughout this topic, have developed targeted outreach programs specifically designed to connect vulnerable populations with legitimate, affordable healthcare options before they turn toward considerably riskier unlicensed alternatives. These community-level interventions frequently prove particularly effective precisely because they directly address the specific access barriers already discussed extensively throughout this topic, providing truly practical, alternative pathways to necessary medical care rather than relying purely on either criminal deterrence or after-the-fact harm reduction alone. Let's talk about the specific ethical considerations medical professionals face when they encounter patients who have already received unlicensed medical care too, because this represents an important, closely related professional and ethical dimension worth exploring specifically. Licensed medical professionals treating patients who disclose previous unlicensed medical care generally face specific professional and ethical obligations regarding patient confidentiality and appropriate, non-judgmental medical care, reflecting broader medical ethics principles that generally prioritize patient welfare and honest, open communication over punitive judgment, recognizing that patients disclosing this kind of sensitive information need to trust that doing so will support rather than jeopardize their own ongoing medical care and legal safety. This professional and ethical framework connects directly to the broader harm reduction principles already discussed extensively throughout this topic, reinforcing the same underlying priority of supporting genuine patient welfare and safety above all other competing considerations. Let's talk briefly about how popular media portrayal of this topic sometimes diverges from documented research reality too, because this represents a final, worthwhile detail before wrapping up this discussion. Popular fictional and dramatized media coverage of unlicensed medical practice sometimes emphasizes dramatic criminal elements or unusually skilled, almost heroic unlicensed practitioners operating for exciting narrative reasons. A portrayal that public health researchers and investigative journalists studying actual documented cases generally find diverges considerably from the more mundane, more truly tragic reality already explored throughout this discussion, involving ordinary people facing seriously difficult circumstances and limited legitimate options, rather than dramatic criminal masterminds or secretly heroic medical outlaws. This gap between popular dramatized portrayal and documented reality is worth appreciating directly, since accurate public understanding of this issue depends on engaging with the actual, carefully documented research and reporting already explored throughout this discussion, rather than relying on popular entertainment media's frequently more dramatized, less accurate depiction of this seriously important public health and social equity issue. Let's zoom out and pull all of these different threads together, because the full picture of unlicensed medical practice turns out to reflect a seriously complex intersection of individual desperation, genuine healthcare access barriers, and in certain documented cases, serious organized criminal exploitation, rather than any single, simple explanation. Patients turn to unlicensed medical care primarily due to cost barriers, legal status complications, or restricted access to specific legal medical procedures, while practitioners range from legitimately trained professionals unable to obtain recognized local licensure through to individuals with little genuine medical training and, in the most serious documented cases, organized criminal networks engaged in serious, direct human rights violations. The genuine, well-documented dangers involved, elevated infection and complication risk connected to inadequate sterile technique and emergency medical backup capability, represent a serious, ongoing public health concern that structural healthcare policy reform generally addresses more effectively than criminal enforcement alone. So the next time this topic comes up, whether through investigative journalism, documentary coverage, or casual conversation, it's worth engaging with it as what it actually represents: a genuine, serious public health and social equity issue reflecting deeper structural problems regarding healthcare access and affordability, rather than simply as a source of shocking specific detail disconnected from any deeper understanding of why this shadow medical economy persists and who it actually affects, which leaves an interesting thought worth sitting with. If unlicensed medical practice persists specifically because legitimate healthcare access remains really difficult or unavailable for a significant portion of the population in numerous different countries, what does that suggest about how effectively any society can actually address dangerous underground economic activity through criminal enforcement alone, without also directly addressing the underlying structural access and affordability problems that create genuine, sustained demand for that dangerous underground activity in the first place?